Hi everyone. So I will present today some assessment we did on the potential impact of COVID-19 on life expectancy. So I did this work with my colleague Raya Muttarak and Sergei Scherbov. Just for the background first, wait, it doesn't, okay. So pandemics can have big impact on life expectancy. This is just to show you an example of what happens during the Spanish flu in 1918 on the life expectancy in the US. This is what we see on the graph here. It was a drop of about 10 years that happens on the period life expectancies. So it was slightly growing, and then suddenly with the pandemics, a big drop. So the secular trend was broken, and then it recovered for the next few years, and so it led to an important impact on life expectancy. So this is a bit the objective that I had in mind when I started working on this. It was to provide the first estimates of the potential impact of COVID-19 on the period life expectancy. So we don't know exactly, the pandemic is still ongoing, so we don't know exactly what will be the total number of deaths. We don't know exactly what are the prevalence rates. So what I did is I built a range of scenario of prevalence rates, range of scenario of age-specific case fatality rates, and then I applied those scenarios to 4 different life tables. So either a very high life expectancy life table, so I pick the life tables of North America and Europe, with a life expectancy of 79.2. High life expectancy life table, I picked Latin America and the Caribbean with 76.2 years of life expectancy. The medium life expectancy life table with Southeastern Asia. And finally, the low life expectancy with Sub-Saharan Africa. And this is important to point out that this is not predictions, of course. This is more, it is a scenario approach. So it is what if. What will happen if these regions reach this prevalence rates of COVID-19 with this specific age-specific case fatality rate. So it's not a prediction, it's not an assessment of what happens in the past, and it's not a prediction of what will happen. So to measure this, we built a micro simulation model, very simple. So a discrete time micro simulation model that will simulate the life of individual week by week for periods of 1 year. I built this in SAS. And this small micro simulation model has some parameters. So first we have a probability of dying from many other causes. This is taken from the UN World Population Prospect, so the QX of the table. We have the prevalence rates of COVID-19. For this, we have no age differentials. And we assume, so it's not distribute uniformly during the years. We assume that there's a peak in the middle of the year. So it starts slowly, it grows, reach a peak, and then it slows down. Another parameter is the length of illness. So we set this as 2 weeks. So when someone gets sick, he's sick for 2 weeks, and then he's ill or dead. And finally, we have the age-specific probability of dying from COVID-19 among the infected people. This is a small schematic representation of the model. So we have 72 weeks. We have 3 main events. So the probability of dying from any other causes, probability of getting infected by the virus. Once the person is infected, it can only happen once. So once the person is recovered, cannot be infected again. When the person is infected, it lasts for 2 weeks, and then probability of dying. So among those who get infected, we simulate the probability of dying. So all those simulations, those probability are simulated with a Monte Carlo approach. So we compare the probability with a random number and simulate if it's happened or not. For each combinations of age group and regions, we did 100,000 simulations. So this is to minimize the Monte Carlo error. So the big question now is, what are the fatality rates? So we cannot really rely on the official counts for the fatality rates, because the official counts, they have many bias. One of the big bias, especially in the beginning of the pandemic, was underreporting of the milder cases. So this creates upward bias in the fatality rate. So at the beginning of the pandemic, especially, people who were not get sick. The capacity of testing was not that big, so those who were not that much sick were not getting reported. They were just sitting at their house, and so at the end, the fatality rate was probably severely overestimated by this. Second source of bias is the time lag between the diagnostics and the deaths or recovery. So when people get infected, they don't die on the first day. It takes usually a couple of days, couple of weeks. So if we look at the number of deaths at time t, we should look back in the past at time t minus something to see what is the real denominator for this. So this creates probably a downward bias in the fatality rate. So this is just report on a map the different fatality rates in the world. So there's a big variation. This is a bit outdated. This took this in June, I think. So in June, some countries had 0.5 fatality rate, and some countries like Belarus, and some country had almost 20%, like in France. So I didn't pick the official counts. I picked instead studies that try to assess the real bias-adjusted age-specific fatality rates. So it has been published in the Lancet. Basically, they picked people that was entering China in Hubei, so everyone was tested, and then you can know the real, like a real prevalence, the real denominators, and you can follow this cohort and see what is the probability of dying by age and adjusting by some other factors. So this fatality rates look like this. This is the central estimates. So very low until the age of 55, 60, then it started increasing sharply and reach maybe 8% for 80 and over. They also provide a lower and a higher credible interval. So basically it will vary between 4% at 80 and plus and to 14%. If we compare with other estimates. So when I did the study, this was the only available estimates, bias adjusted estimates. Now they have some new. So the Institut Pasteur of France, they also try to modelize this. Basically, it's linked to the lower estimates I use, except for the age group 80, which is about the same as the central estimates. But if we compare with the reported data, so in Korea, where they did good testing, it's about the same as the central estimates we have. And in Italy, it's much higher because of the bias that I explained before. Yeah, we'll skip this. Okay. For the age, for the prevalence rates, I didn't use age-specific prevalence rate. So for each scenario I built 6 scenarios, so from 1% to 70%, and it's the same for all age group. Because there's no clear pattern into prevalence rates. In some countries, it will be higher among the elderly, some countries it will be higher among the young. So it depends a lot about the capacity of testing of the country or the strategy of testing. So for the simulation, we keep the same rate for all age group. The result now. So this is first for high life expectancy, very high life expectancy regions. So basically, for each increase of 1% in the prevalence rates of COVID-19, we have a decline in life expectancy by 0.1 here, which means that at 10% of prevalence rates, we can see 1 year decline in life expectancy. It increases, and then finally at 70%, we will reach, according to those estimates, about 7 years. When we look at the lower estimates of age-specific fatality rates, it will be lower, about 4 years, and with a high upper threshold, it will be almost 11 years. So between 4 at 70% will be between 4 and 11 years of life expectancy loss. What I did also is I calculate the total fatality rates when using the age structures of North America and Europe. So basically, I apply the fatality rates to the age structure, which is like a older population than life than a life table, and I see what will be the fatality rates, total fatality rates, using those estimates. So basically, it will lead to a fatality rate of 1%, twice lower for the lower interval and twice higher for the upper credible interval. Just to show on a graph how it will look like. So this is the life expectancy in Sweden over years. and the projections until 2030. At 1%, it will look like this, the impact. So basically the secular trends, it increase maybe 0.2 year per year life expectancies. So at 1%, this secular trend will break and then it will recover. Very small impact. At 5%, we see a clear break in the trends and it getting bigger, bigger, bigger. And at 70% at the ends, we have a big drop, and the life expectancy for this specific year will be something like same as back as 30, 40 years ago, maybe. And then it will recover likely, we hope, the next few years. Result now for the Latin America and Caribbean, so high life expectancy regions. It's very similar to the very high life expectancy regions. So we lose 1 year of life expectancy at 10%. At 70%, we lose a bit 6 years instead of 7 years. What is interesting is that when we calculate the total fatality rates in Latin America and in the Caribbean, so using the age structure of those regions, we have fatality rates much lower than in North America and Europe. So it was 1% in North America and Europe. Here it's 0.5%, twice lower, because there are much less people in the other age group. Now this is for Southeastern Asia. So the life expectancy is lower. Life table is give a lower life expectancy on those regions. And then we see that the impact of COVID-19 on life expectancy is much less. So we lose the first year of life expectancy at 15% instead of 10%. So basically the higher are the mortality rate at older age, the lower is the impact of COVID-19 of life expectancy. And this is obviously because someone, when the life expectancy at 70 years, for instance, is 20 years, the number of potential of year loss is much higher than when the life expectancy at 70 is 2 or 3 years, for instance. Now in sub-Saharan Africa, the impact is much, much lower than the other regions. So the first year's loss in life expectancy is reached only at 25% instead of 10%. And even at 70%, using the central estimates, it will be 3 years of life loss. And the total fatality rates when using the age structure of sub-Saharan Africa, it's only 0.2%. This is, of course, all things being equal, which is not the case in the reality. So fatality rates 5 times lower than in North America and Europe. It's a bit hard to compare what I did with other studies. So now there are some studies that try to already assess using the excess of mortality, what is the impact of the first wave on life expectancies. It's not directly comparable with what I did because the true prevalence rates is still unknown in most cases. And also the excess of mortality can be directly or indirectly related to COVID-19. Indirectly would be, for instance, if the hospitals are overloaded, then it can be excess of mortality from other causes that will not be counted as COVID-19, but it's still indirect impact of the virus. So up to now, the other studies showed already an impact of 1.5 years in the US. This was in June, maybe 2.5 years in Peru and Ecuador. Simone Giustandi et al. Measure about 3 years in Bergamo in Italy for April. About at the same time, there were studies showing maybe 50% of antibodies in the population of the region. So that means that it will correspond to the lower estimates of my estimates. Already 1 year, yes.
The 2 minutes.
2 minutes. Yeah, yes.
Yes.
This is my second last slide. Yeah, so in Spain, about 1 year already. Now it's probably higher because this was again in March only. So now with the second wave, it's probably higher. Yeah. So in summary, as long as the prevalence of COVID-19 is low, it will not affect the life expectancy a lot. But as soon as it's reached a certain percentage, maybe at 2%, we will see probably a break in the secular increase in life expectancy. So it increased by 0.2 years in average per year. So at 2%, this increase is canceled. And at higher percentage, eventually we see the break will be higher and higher. So I did this calculation for broad regions, so the continents, but my estimates can be applied at smaller level. So I just use a life table basically of the broad regions, but small cities or small regions that have similar life tables than the region I use, my estimates can be still applied to those regions. And finally, some limitations. This should be interpreted in the context that all other things are kept constants, and this is, of course, unrealistic because the true age-specific case fatality rates obviously differ among regions. So now I use the same age-specific fatality regions in Europe than in Africa in the central estimates, but the health infrastructure is very different, and the way country will respond to the pandemic is also very different. So in the reality, it's not the same among countries. And also the mortality rates are not independent of the prevalence of COVID-19 infections. So probably that the higher the prevalence rate is, the higher will be the mortality, especially if the prevalence is concentrated in time, because eventually hospital will be overloaded and treatments will not be as good as when the prevalence rate is very low. So we might expect maybe higher life expectancy according to different prevalence rates. And this ends my presentations. Thank you.